gallbladder and biliary tract diseases in dogs and cats. So in cats, the bile duct and pancreatic duct join before entering the duodenum. This is how they get triaditis, which is cholangitis, pancreatitis, and duodenitis. However, dogs have two separate ducts. Cholangitis is hepatobiliary inflammation. It is the most common chronic hepatic disease in cats. Neutrophilic cholangitis has two forms, acute form and chronic form. Acute form is just neutrophilic infiltration of the bile duct, and chronic form is neutrophils and lymphocytes. It's a mixed inflammation. Discuss the clinical signs and the diagnosis. Lymphocytic cholangitis is the most common cholangitis in cats. Discuss the pathogenesis, the clinical signs, the differential diagnosis, and the prognosis. For the treatment of cholangitis, you can give antibiotics such as amoxiclav and metronidazole, give analgesics such as butorphanol because cholangitis is very painful, and you can give anti-inflammatories. You can give UDCA, which is ursodeoxycholic acid, with prednisolone, and also give a hepatic diet. For the surgeries, you can do a cholecystectomy, which is a gallbladder removal, or a cholecystoenterostomy, which is drainage of bile. You can have a duodenal connection and a jejunal connection. Cholangitis is hepatobiliary inflammation. Mostly the biliary tract is involved, but the liver can be involved as a secondary process. It can be neutrophilic, which can be acute or chronic, or lymphocytic, which is the most common in cats. And liver flukes can also cause cholangitis. So for neutrophilic cholangitis, there's an acute form. It's a neutrophilic infiltration within the bile duct. It's caused by an ascending bacterial infection. There can be a translocation through the GI wall or through the blood. It is typically E. coli, Enterococcus, or Clostridium. The predisposing factors are cholates, aka gallstones, or pancreatitis in the case of triaditis. In the clinical signs, it can happen in young, middle-aged, or old animals, and there's no sex predisposition. Animals can have acute vomitus, diarrhea, and dehydration. And they can also get icterus and abdominal pain. In chronic neutrophilic cholangitis, it's a mixed inflammation. It can have neutrophils and lymphocytes. It can cause biliary hyperplasia. And there's an unknown etiology, but bacteria can cause persistent inflammation, or it can be immune-mediated. In the clinical signs, it can be seen in older animals, around 8 to 9 years old. And we can see weight loss, vomitus, and icterus. The icterus in both cases is due to intrahepatic cholestasis. In the lab diagnosis, we can see leukocytosis, so a neutrophilic left shift, especially in the acute form. To diagnose, you need to do a fine needle aspiration, also known as cholecystocentesis. This way you can do a bile culture, and it's normally E. coli. Make sure you don't do a fine needle aspiration of liver tissue. Lymphocytic cholangitis is the most common form of cholangitis in cats. It is common, it's slow progressing for years and months. It's mostly in the portal area around the bile ducts, compared to the acute form, which is around the lumen. So the bile ducts experience inflammation. This leads to biliary proliferation and hyperplasia and fibrosis, which leads to cholestasis. The pathogenesis of lymphocytic cholangitis is unknown. It's expected to be immune-mediated. However, immunosuppression treatment does not solve it, and the bile culture is usually negative. In the clinical signs, it mostly affects young or middle-aged cats, so less than 4 years old, and they're younger than the neutrophilic chronic cholangitis cases. Persian cats are predisposed. It's a slowly progressing chronic form. The animal does not appear sick compared to the neutrophilic form. However, in some cases they can develop ascites in around 30% of cases, and the total protein is high and the albumin is low. Therefore, we know the globulin is high. Ultrasound is very important. There's a wide irregular distension of the common bile duct. There can also be common bile duct obstruction. The diagnosis cannot be done without histopathology. We can see lymphocytic infiltration of the portal area and hyperplasia. The prognosis is not great. They can survive to 1 to 3 years, but there's no recovery. It may even lead to biliary cirrhosis. The differential diagnosis of lymphocytic cholangitis can be FIP and EBDO, and lymphoma and lymphosarcoma. The treatment of cholangitis are antibiotics, analgesics, and anti-inflammatories. So antibiotics are mostly given in the acute suppurative form, so the neutrophilic form, and they're given before glucocorticoid therapy to eliminate the bacteria. So it's mostly amoxicillin and clavulanic acid and metronidazole. In chronic reoccurring cases, you give fluoroquinolones. In neutrophilic cholangitis, they're stabilized given fluid therapy. And patients also have to be given analgesics. They're given opioids such as butorphanol. This is because cholangitis is very painful. Anti-inflammatories are also given because there's an immune background to the disease. So for the anti-inflammatories, prednisolone is the first choice. It's given for minimum 6 to 12 weeks at the lowest effective dose. But before the prednisolone, you give UDCA, which is ursodeoxycholic acid. So you start the treatment with the antibiotics and UDCA, and then you give prednisolone. Or you can give prednisolone alongside UDCA. UDCA is a hepatoprotective. It avoids mitochondrial damage, and it's also an anti-inflammatory. It's very effective in cholangitis. The only contraindication is when there's a mechanical obstruction. So for the diet, you can have 2 days of an oronasal tube, and once it's stabilized, you can do an esophagotomy for 4 to 6 weeks with a permanent tube. And for the surgeries, there are 2 procedures, cholecystectomy and cholecystoenterostomy. Cholecystectomy is a removal of the gallbladder. The indication are cholelithiasis, which are gallstones. And in the case of cholecystoenterostomy, this is when there's an obstructive common bile duct. You can make a duodenal connection or a jejunal connection. For the duodenal connection, you basically make a side-to-side anastomosis between the gallbladder and the duodenum. You do the same with a jejunal connection, but even though it's less physiological, it's more easy to perform the surgery. If the gallbladder is inflamed or has stones, it is still forbidden to remove if patency is not present.